We do have a special guest, Dr. Beatrice Leung, all the way from Toronto, Canada. Dr. Beatrice received a Doctor of Dental Surgery degree at the University of Toronto. After graduation, she completed a General Practice Residency at the Boston Medical Center and a 3-year Prosthodontics Residency at the University of Pittsburgh. During her residency, she earned a Master's of Public Health degree. And upon completion of this program, she became certified as a Fellow of the Royal College of Dentists in Canada, as well as a diplomate of the American Board of Prosthodontics. Since then, she's been in private practice in midtown Toronto for the past more than 15 years. And she's had a long history of involvement in prosthodontic education at the University of Toronto, and recently joined as faculty as an assistant professor. I don't know if her position has changed, but she's been awarded several awards for teaching at that university. Dr. Leung, it is a privilege to have you in Dental Webinar Series today.
Thank you for having me.
All right. So guys, if you have any questions, you put it in the Q&A section. So at the end, or maybe at some point, she will stop and take a look and answer your questions. But do go ahead and welcome from everyone. If you are from Nigeria, I want you to type in there, Nigeria. If you're from Kenya, just know where you are while she gets started. Take it away, Dr. Leung.
So would you like me to start?
Yes, ma'am.
Okay. All right. So I'm going to share my screen. All right, so good afternoon. It is noon time here in Toronto, and I think it's 5 o'clock in Africa, where this may be being held, or maybe your time zone is a little different. But thank you for taking the time to listen to my presentation. So just a bit of background, and I did ask Uvo who my audience is because I wanted to make sure that I cater the material to the appropriate crowd, but I understand that this is a mixture of dentists, dental students who may have very little experience in implants, or maybe who have some experience in implant already. So what I've prepared for you today, I'm hoping that it's going to be useful in one way or another. So what I have, so thank you, Uvo, for inviting me. This is the second time that I think I'm presenting to your group. The first time, it was about a year ago. I was asked to talk about broken screw, which was a prosthetic complication that is very popular here in North America. As we're doing more implants, we're seeing more complication, and that is one of the things that I always see. So I end up being invited to talk about this topic. So I've been asked to talk about the basics of implant restoration. Now, before I talk to you about what I want to talk about, I just want to give you a little bit of background. I think Uvo already gave you a brief background of myself, but this is just a quick summary again. You know, I was born in Hong Kong, but then I moved to Canada when I was 10. So basically, I did my undergraduate university training at the University of Toronto. I did my dental school there as well. I graduated in 2001. After I graduated from dental school, I was really lost, and I moved to Boston. I did a year of GPR there. So when I was there, I was treating the medically compromised patients. Actually had a lot more surgical exposure there, because I was actually on call with a lot of the oral surgery residents. I was in the OR, so I was able to understand the setting of the hospital dentistry, and also understand what the oral surgery residents do in that setting. But after 1 year there, I decided to do prosto. So that's when I moved to Pittsburgh to do a 3-year program there. And at the same time, I did a Master of Public Health there. So I finished everything in 2005. And then I moved back to Toronto, which is where my family is. And I've been in private practice ever since. And so as a prosthodontist, I also have been trained to do the surgical placement of implants. So that is one aspect that, even though I'm not talking to you about the surgery today, I have an insight about the surgical procedures, and I'm aware of the challenges that can take place between the surgical and the prosthetic aspect of implant dentistry. My teaching background on and off was a clinical instructor between 2005 and 2008. And then after about 10 years, I went back to university and also started teaching. But then I really went back to do more academia in about 4 years ago. And that's when I started being assistant professor. I am a course director for third year undergraduate prosto there. And so it was during that time I get to see and understand more challenges of the dental students and understanding implants, and also just from colleagues coming to me about their challenges of implant dentistry. And so with all that experience and my private practice experience and my teaching experience, if you actually want to learn more about my journey as a prosthodontist, I actually have a blog, which is called Prosthodontics Pearls, which is just really information that I want to share with the public dentists. Just, the learning that I've had, the mistakes I've made, and it doesn't just talk about implants, it actually talks about everything else. As a practicing prosthodontist, what I've learned, what I found difficult, and so I share on this platform, which you guys might want to look at just to learn more. What's more important is that I also have an Instagram account. Also, I post videos of things that I find interesting for the dental students. I actually get inspiration from the dental students to think the questions they ask me. I try to turn it into a learning moment for them and create posts and also videos for them. And so I think that's how Yuval found me on the Instagram platform, asked me to present this topic of implant restoration. I also do an implant course for the Ontario dentists here, and which is what a lot of my material is going to be based on this program, because I actually do a 5-day didactic and hands-on program geared for dentists talking about prosthetic implant dentistry, because a lot of the materials out there, I find that is more surgically oriented. And when I see what the dentists and the dental students are struggling on the prosthetic aspect, so my classmate asked me to put together this program with a lot of hands-on activity. And I think you will find this useful in helping you disseminate your program for the dentists in Africa. Because what I've done is I put together a lot of information with hands-on activity. These activities are designed to highlight some of the challenges you might see when you're actually doing the implant dentistry, the prosthetic aspect, which I don't see a lot of people talking about it, but I see the challenges from the dentists and the dental students. So I have a lot of these models created from this program to kind of support the didactic portion of my lecture. So a lot of what I'm presenting to you are the didactic portion of what I do in this course, but there are other hands-on components that you might find useful. Okay, so let's just start. What am I here to talk about today? I know that you will want me to talk about the basics of implant restoration, but I wanted to set the stage correctly so that you know what I'm aiming to present to you. In my mind, when I'm talking about prosthetic treatment, there's so many options out there. Historically, there's the fixed prosthetic treatment, and then there's the removable. Implant dentistry fall into both categories, both fixed and removable, okay? What I want to talk to you today really is going to be mostly for the fixed solutions, using implants as a solution, either for a single missing tooth or maybe multiple missing tooth, a short span scenario. So something simple. So that's what I really want to talk about, because I think I just want to start with something basic. Okay. Now, in my course, what I like to do is I always organize the information into a roadmap. So that way, my students won't get lost as to where I'm going, where am I at, in terms of this roadmap. And my roadmap, there are two types of roadmap. One is learning how to plan and diagnose a case. If you have a case you're thinking about implants as a solution, where do you start? And this is the roadmap that I've kind of designed for my students to follow so that you won't get lost, okay? So the blocks of knowledge that I want to present to my students are along this roadmap. So you will see on this slide that the roadmap start with, topics on restorative space analysis. We also have to look at the hard and soft tissue. We also have to look at the aesthetic influence of the case. I'm going to call that the aesthetic influence. And then also, along with the aesthetic, I want to look at the functional influence of the case. And along this roadmap, you have to factor in the patient, okay? And so this is kind of the roadmap that I will teach students how to plan an implant restoration. Similarly, once you have a plan and you've executed it, the plan the way you had in mind, I also have another roadmap for the students to follow. Once the implant is in the mouth, you're ready to restore it. What are some of the information you need to consider? And so this is kind of like the roadmap that I prepare for my students to follow, these blocks of knowledge that they need to understand. And so along this roadmap, you'll see that I have a topic under pre-prosthetic planning and records. What type of information do you need to obtain, and how do you plan the case properly? So that's the first step. The other step that I always teach my students to understand is understand what type of design out there and what type of material that you have at your disposal to consider in restoring the case. Okay. Once you have that plan, you have a design in mind, obviously you send it to the lab. And when you get the case back from the lab, what type of delivery consideration you have to keep in mind. Essentially, how do you insert the case? What is the sequence of procedures you need to check in order to predictably deliver the implant restoration smoothly? And once that's delivered, what type of post-insertion follow-up that you need to understand and to give to the patient? And I always follow up with the common prosthetic complications that you might encounter along this roadmap, okay? The challenges that I see people going through. So that's the usual information that I like to discuss with my students. For today, because I don't have 5 days, I only have 1 to 2 hours with you guys. So what I really want to do is just to highlight some of the things that I think are going to be critical and important for you to start planning. So I'm going to talk about the roadmap to planning implant restoration. I'm not going to go through a lot of things in detail, but I think I'm going to talk enough so that you have an idea what it is that you need to think about when you're planning for an implant restoration. I also want to talk about, the delivery part of the treatment. I don't have 3 days to talk about this material, but what I want to talk about is specifically the delivery aspect of the implant restoration. When you're delivering the single crown or 2 implant crowns, what are the things that you need to do in order to get it done properly? Now, Uvo also asked me to include talking about making temporary implant crown. Okay, so I also have a 2 days advanced course where I talk a whole day about making temporary crown specifically for anterior teeth. So I'm going to talk a little bit about how to make temporary crowns because Uvo wanted me to include that into today's presentation. Okay, so you can see that I have a lot of things I want to talk about, but I don't want you to get lost in the picture because a lot of the information sometimes I will go in really detail, sometimes I will skip over it just because in order to fit all the information I want to fit today, I have to kind of pick some of the things I think are more relevant to you guys at this stage. But definitely, I just want you to see where I'm at. Okay. Okay, so let's start about just talking about planning the case, okay? This roadmap that I have, I said I always start with looking at the restorative space to begin with, which is really, part of the overall consideration where I kind of talk about these factors under local factors, global factors, and patient factors. Now we're just zooming into a particular area. You may have a tooth that is going to be extracted soon, or you may have a patient that has the tooth missing already and you're interested in an implant for that site. Where do you start? Okay, so that's where we're at. So basically, when you have a situation like that, I look at the space. Okay, so I ask myself these questions. That particular space that is missing or about to be missing, what exactly are you missing? Or what exactly are you going to be missing soon? Okay, is it going to be tooth only? Is it also going to be gum and bone? Okay, and that has bearing on your restorative plan, okay, and also your surgical plan. And the question is, is this a case where you have a lot of bone to work with, you have a lot of soft tissue to work with, or if it's a case where the tooth was lost due to accident, due to advanced periodontal disease, there's no tooth, no gum, and no bone. Okay, so that's the first question you have to look at and answer. And the next question is you ask yourself, what are you trying to replace? Okay, it's not always exactly the same answer because it also depends on a lot of other factors. Okay, so I just want to show you two examples. Okay, the picture on the top is a patient with a missing anterior central incisor, tooth 2-1. And this patient was subsequently restored with an implant. And this is an implant that I place and I restore. And you can see that the actual implant crown is almost a mirror image of the adjacent tooth, which means my prosthetic treatment really is just restoring the crown itself. I was able to have adequate bone and adequate soft tissue to support this restoration, so it blends so nicely to the surrounding area. And so in this case, what the patient was missing was just the tooth, a little bit of soft tissue, a little bit of bony defect, but what I'm trying to replace is just the crown itself. Okay, so it's very important that you can see that end goal for your treatment so you can communicate with the patient. Whereas in the bottom picture, this patient, and you'll see along my presentation how I'm going to talk about this case a little bit, is that this patient, you can see that the patient is missing 4 teeth, and the patient has ended up having 3 implants, restoring the 4 teeth. And I say 4 teeth, but really, in my mind, I'm trying to replace both the teeth and the gum and the soft tissue that was missing. In this case, from the very beginning, when I look at this case, I knew that the biology and the existing condition of the teeth, I am not just missing tooth to begin with. I am missing both teeth, soft tissue, and bone. And even with the best type of soft tissue grafting, bone grafting, I know that my prosthesis is going to involve a little bit of not just also some pink prosthetic. You can see that we have provided some pink porcelain here because I know immediately from the very beginning is that I'm not looking at just replacing the tooth. I'm actually looking at replacing both tooth and gum. Okay, so it's important to identify that very early on. So I can manage the patient's expectation. I can tell the patient immediately in the beginning that in this case, you're really looking at perhaps the crowns to be a little longer, or if not, if that's aesthetically not pleasing, we might have to use some pink porcelain. Whereas the first top scenario, all I'm really just trying to manage expectations that the gum level may not be even, but I am trying to restore the space as closely as possible to the adjacent teeth based on the biology of the bone and the soft tissue that I can see at the very beginning. Okay, so that's very important. Now, sometimes you don't always know what you're missing. Okay, maybe you just don't know what's underneath there. And that's okay. And so part of the planning in the beginning is you have to figure out what is there. And so that means you might have to order a cone beam CT. Okay. And sometimes you may be left with a prosthetic space that you just don't know what is missing and what you're trying to replace because you can't visualize it. You know, it's not like, so obvious. And sometimes that means you have to actually do a diagnostic wax up. Okay, so those are the two additional information that you need to know. So even though you start looking at the restorative space, you think you know the tooth is missing, you think the gum may be missing or the bone is missing, you don't have a full picture. Sometimes you need additional information, and that comes in the form of a cone beam CT or a diagnostic wax up. Okay, so take a look at this case. This patient is missing tooth 2-1, but her existing partial denture had a diastomer in it. Okay, and so when we're looking at replacing this space, she asked if I can close the space. And so the question is, of course I can close the space, but is that what she really wants? And sometimes it's very hard to know what the patient wants. And you can see the picture on the left, if that's what the patient wants, the positioning of the implant is going to be very different than the picture on the right side where we try to close the diastema. And sometimes you think the right side looks better on the model, but when you tried it in, it may not look right. So sometimes even if you think you're just missing one tooth, for you to figure out the restorative space, it's not obvious. It's not always so obvious. And so if you cannot figure it out just by eyeballing it, you actually have to do a tooth setup in order to visualize it. So you have something more concrete to go by, because aesthetic and the spatial analysis, sometimes if the space is a little bit wider than usual, or the teeth are not proportionately well proportioned, sometimes you just don't know. And so you need to do a diagnostic wax up. Okay. And so this is another example. This is a patient who had some facial trauma. It was a gunshot wound in the face, and the patient subsequently had some jaw surgery to repair the jaw fracture and had some orthodontic treatment done to realign the teeth. Now, by the time she came to see me, she was already in braces, okay? And when she came to see me, you can appreciate that, yeah, if you count the number of teeth, she's missing 3 teeth, 1 lateral incisor and 2 central incisors. But the problem is, when you look at the space, it's quite large, and you can see it, even the orthodontists couldn't figure out the space. They pick up a slab of 3.5 denture teeth and just shove it into that space. And we know that doesn't look right. And so before you start planning where the implants need to be, you need to figure out the space properly that looks aesthetically correct and functionally correct. I cannot plan the implant positioning based on this slab of acrylic. You can see that this is not right. But if you did plan your implant positioning, your outcome will be less than optimal, because it will look not correct. It will not look aesthetically pleasing. So what I ended up doing is I just, did my own diagnostic setup to arrange the teeth in the proper alignment that would have proper balance of proportion based on the natural adjacent teeth. And you will plan based on this setup, not this setup, okay? Another thing is, when you're dealing with not a single tooth, but multiple missing teeth, I start to think about biology, because even though you can set some teeth in that space alone, because of the rich resorption, the patient may not look adequately supported by the teeth alone, and might need actually a flange. So that really affects your treatment planning, okay? So this is a patient, even though the patient doesn't want implant here, but I'm just trying to illustrate this case to you guys, how, the lab gave me a setup of the anterior teeth. We're ready to make a new partial denture. You can see that we made server crowns with attachments. The lab sent me just the teeth setup with just a little bit of wax in the area. And so even though the teeth look like nicely aligned into the space here, when I look at his overall lip, you can see the lip is not supported. Okay. And so I am asking the lab to give me back a setup to give me a flange, a pink flange, because I need to evaluate how much of the flange is needed to give him a proper lip support. So when you start looking at a large edentulous case, even though you think you want to provide a fixed solution, your fixed solution may not give you adequate lip support for this particular patient. And so that will influence your decision about what treatment solution is more appropriate for the patient. If you plan this case based on it's a fixed solution, you don't have a flange, and you don't have a flange, and your outcome, you might have teeth, but you might have teeth with improper lip support. And that may be okay for the patient. But if you have a patient who is very aesthetically aware, who can see that the lip doesn't look quite right, and that may have been the wrong solution for this patient. Okay, so basically the first step in your treatment planning, diagnosing analysis for an implant solution is look at the space, look at the restorative space. If you don't know what space you're dealing with, you might need more information. And that might be in the form of a cone beam CT, or you might need to do a diagnostic wax up to figure it out. And once you do that step, a couple of things might end up happening. You just have to maybe inform the patient the expected outcome. Maybe this implant restoration is going to look like you need pink porcelain, or maybe a fixed solution is not the right solution. You might need a removable solution, still implant supported, but it's going to give you a flange to give you better lip support if you want the desired aesthetic outcome. It also outlines some of the other areas that, maybe other teeth needs adjustment. Maybe it needs bonding, maybe need crowns, maybe need just a little bit of enamelplasty. Maybe implants is not the right solution altogether. Okay, after you figure out there's no bone, you might need bone grafting. And so those are the thought process that you need to go through before you arrive with a plan. Okay. So once you have the teeth set up or you have an idea how many teeth you're dealing with, that's when I start to look at what kind of implant design am I hoping for. Okay, now that requires you to understand some of the requirements for different design. And you might say, well, for single tooth, what kind of design you're looking for? Is an implant crown? It's an implant. It's an implant. I need an implant to restore an implant. Well, you have to know what type of design, and the design we're looking at is not very complicated, but you still need to know the differences. Okay, so for a single unit, the two type of implant designs that you have to think about is either a screw retained crown or a cement retained crown. Okay, when you have multiple missing teeth, you have different options. You can think of all these multiple missing teeth of a multiple units, single units, or you might want to splint them, or you might consider them as some sort of a bridge or a combination of. So you have a little bit more options here. Okay, but basically you have to know the design requirement between a screw retained and a cement retained implant restoration. Okay, so this is just very basic stuff if you don't already know. For a single unit implant crown, one of the options is a screw retained crown. And what does it mean? It means that you have an implant where the crown is connected to the implant through a screw. So this is an example. You can see that on the lingual surfaces, an opening where you can access the screw. Okay, so schematically, this is what you would see. You have an implant. You have an implant crown, but the occlusal surface has an opening where the screw will go through and actually secure this implant crown to the implant. So that's called screw retain implant restoration. Okay, there's another type where we call a cement retained crown. So this is an example of a cement retained crown. There are 2 teeth missing, but they're treating it as 2 individual implants. Okay, so you can see that the implant has an abutment, and on that abutment, that's where the screw is securing this abutment. The implant crown just kind of sits over top on this abutment. So you can see that the 2 crowns are individual crowns. They are individually seated on these individual abutments where the abutments are connected to the implant. Okay, so schematically, this is what it will look like. You've got an implant, you've got the abutment, you've got a screw that secures this abutment onto the implant, and then you have a crown that has no opening, no access to the screw, but it just is going to be cemented over this abutment, just like a regular tooth crown. So this is the design that is more familiar to dentists who are used to doing crowns, because you have a cap that sits over an abutment that looks like a tooth prep, but this is an abutment that is actually screwed onto the implant. Okay, so the next question is, how do I know which one to design for the patient? Which one is better? Which one is worse? So I put together, I think this is an article that I really find that it's useful, because it's a decision tree that helps you to decide which is more indicated. Okay, now the movement, you have to understand, if you haven't been into dentistry long enough, is that when implant dentistry first came out in the 80s and the 90s, there were a lot of people who were doing cement retained crowns. And then we got back to doing screw retained crowns. So the movement now is that we're doing a lot more screw retained crowns, because we have learned that when you do cement retained crowns, if you don't clean out the cement properly, that can give you a prosthetic complication of peri-implantitis. Okay, so that is something that we've learned over the last 20-30 years, that when we are doing cement retained crowns, which is what I find a lot of my classmates are more familiar with, because it's similar to their natural crown, and so it's cemented on it. But what we found is it's not easy to clean out the cement. And what happens is these retained cement get stuck underneath the gum, and that can be a source of the problem to peri-implantitis, leading to bone loss and infection. Okay, so the movement now is, whenever possible, we aim to have screw retained crown. So if you look at this decision tree, if you have an anterior or posterior implant, if you have an ideal position, ideal position of the implant, they recommend whenever possible to do screw retain. If you have very limited interocclusive space, that is also an indication for a screw retain crown. Okay, so it says here, if you only have about a 4 millimeter interocclusive clearance, that is clearly an indication that you need to do screw retain. You cannot do cement retain, because for cement retained crown, you need to have a certain height for the abutment to have proper retention and resistance form for the crown. Okay, the only time when we wanted to do cement implant crown is when we end up having an implant that is not positioned ideally. Okay, so even for posterior or anterior, if you have an implant that is not positioned ideally, so sometimes you have to do cement retained crown. However, if you have to do that, now they will recommend that make sure when you develop your custom abutment for the cement retained crown is that you don't have the crown margin too subgingival. You can only be about 2 millimeter below the gum line, because you want to be able to access that margin to clean out the cement. Okay. Now, there are also times when the space is so small, mesial-distally, that you might have to end up using a cement retained crowns, because the screw access will result in the proximal surface being too thin. Okay, so sometimes you may find yourself that you need to do cement retained crowns just because the space is too small to incorporate a screw retained crown. Okay. And another reason why I might want to use a cement retained crown is simply the patient does not want to see an access hole. Sometimes people do consider a screw access hole an aesthetic. I find that. And so that's why I wanted to talk about these design considerations at the very beginning, because that's going to have bearing on the surgeon of how to position and how to line up the implant, how deep to place it, and buccolingually how to aim for the positioning and the angulation of the implant, because they are slightly different. If you're aiming for screw retain restoration, the position and angulation is slightly different than a cement retain restoration. Okay, and how much space you need to factor into occlusally, they're also different. Okay, sometimes if you don't have a lot of space to work with, you know that you have to do a screw retained crown no matter what, and so you have to make sure the surgeon now has to place it in a way to give you that space. If they don't place it deep enough and you don't have the space, then you're going to have prosthetic complication. Okay, so in summary, you know, at the beginning of the roadmap, you've decided, you know, you're going to have an implant for this scenario. You're going to look at the space. You want to make sure the space is adequate. You have to have a design in mind. I think in this space allowed, you can aim for screw retain restoration. If you don't think you can aim for a screw retain restoration, it's going to be a cementable restoration. You want to make sure you have enough space for that. Okay. The advantages of a screw retain restoration is there's no cement, so we don't have to worry about peri-implantitis. It is indicated for very limited interocclusal space. So when you start looking at your restorative space analysis, you see you have very limited interocclusal space, or once you've done your diagnostic wax up, you know that there's not a lot of space. Immediately, that's your red flag that I need to make sure this is a screw retain restoration case. You have to communicate that to the surgeon to make sure it's placed deep enough to allow for that space. Okay. And also you have to make sure that in order to do a screw retain restoration, the implant is well positioned. So that's where planning comes into play. And you need at least, to me, 5 millimeters of space in order to make a screw retain restoration work. Okay, for cement retain restoration, we are worried about peri-implantitis, but if it needs to be the design for whatever reason, because the implant wasn't positioned as ideal as we like it, then you want to make sure the abutment where the margin ends is not too subgingival, so we have access to clean out the cement. Okay, but most of the time we use cement retain restoration for malpositioned implants. You do need to have a certain interocclusal space. Usually they say that it's about 8 millimeters or more in order to make sure your abutment has enough room to develop that retention and resistance form for the crown. The disadvantage of a cement retained crown is that it's not easily retrievable. Okay, we do tend to use temporary cement, but sometimes even if it's used with temporary cement, the crown, if it needs to be removed, it's not easily removable. Okay, so that is one disadvantage of using a cement retained implant crown as your design for your case. Okay, so that is just the first, you know, step of planning, deciding what restorative space you have and deciding what design you want. Are you looking at screw retain? Is it cement retain? Are you dealing with it as a single unit? If you have multiple missing teeth, are you splinting that? Now I have a whole lecture on splinting, when to splint and when not to splint. I don't have time to talk about that, but that's another decision factor. You have to have a design in mind so you can discuss that with the surgeon. Okay, are you dealing with a case where you're going to put one implant per tooth, or you're dealing with an implant bridge where you might have 2 implants to support 3 missing teeth? Okay, so that's the first block of information you need to figure out in your roadmap. Now what I want to do is just really quickly talk about the rest of the roadmap. If you look at the roadmap, the next thing that I will talk about is the hard and soft tissue evaluation. Once you figure out where the teeth are, where the teeth need to be, and once you figure out it's where the implant should be, and this is a spatial decision. We talk about occlusogingivally, how much space we have. And this is where we know that if you are in this picture, if you're looking at 2 missing teeth and you're looking at 2 implants, and then now you're looking at the space between the adjacent teeth and the buccal contour of the restoration, and that will tell you how to plan the positioning and the angulation of your implants properly, knowing whether it's screw retain or cement retain, whether it's single or splinted. So that will now, with the cone beam CT, with the diagnostic wax up, with the occlusal evaluation, you will have a better idea how to plan the position and the angulation of your implants with this information in mind. These numbers are very important to remember. And if you understand the biology, you know why you need to leave a certain amount of space between the adjacent teeth for the bone to preserve the bone papilla. You need to have 3 millimeters of space between 2 implants to make sure that there's enough soft tissue between that, and so it's self-cleansable. And buccolingually, you want to make sure that you know where the buccal contour of your restoration, and you leave enough bone to support the buccal aspect of the implant. Okay, so all of these numbers comes from an understanding of biology and how bone needs to, how much space between the bone and the teeth and the implant in order to have good soft tissue support and to ensure that you have enough restorative space that is self-cleansable, that is hygienic and functional. Okay, so once you have that, that will now tell you whether you have the bone and the soft tissue to support your implant restoration. Once you have your design in mind, you know where the position, the angulation needs to be. Now you go back and look at the bone from your cone beam CT, and from your soft tissue, now you know whether this is a case that needs additional hard and soft tissue augmentation. And then that's when you start to collaborate with the surgeon, what type of surgical procedures are needed to reach this end goal, okay? Whether this patient needs bone grafting, soft tissue grafting. And then the question is, what are the sequence of these procedures? And everyone is different. Like I said, I'm not here to talk about surgical treatment plan, but I know enough that there's so many ways to do these procedures, and everyone has a different way of doing it, which is going to affect the sequencing aspect of your treatment plan. You also have to think about the loading protocol. When is this implant going to be ready? If it's going to need all these additional procedures, what it's going to impact me as a restorative dentist is that how long is the patient going to be without teeth? Because if you're going to need bone grafting and soft tissue grafting, and you need a certain number of months for the implant to heal before you can load it, then if it's an aesthetic area, you might need a provisional restoration, whether it's an implant crown, provisional implant crown, or an Essex appliance, or an acrylic partial denture or flipper. That is information that I need to figure out so I can develop my plan properly, so I can deliver the information to the patient so that they're not left out in the plan, not knowing when they're going to get to teeth. So oftentimes I find that this is a step that communication breaks down, because even if you want the information, you don't always get it because the surgeon may not be able to give you all that information at the beginning. So it takes time to communicate with the surgeon and let them know what are the information you need so you can cater your prosthetic plan properly and provide better communication to the patient. Okay, so that's the next block of knowledge that I just really skimmed through in 5 minutes. The next information that before I finish my planning is I step back in the overall case. Whether you're dealing with 1 tooth or 2 teeth, I always step back and look at the patient's functional status. And what do I mean by functional status? In my definition, I wanted to understand what type of occlusal forces is in the mouth, okay? Because the longer you practice dentistry, the longer you realize that if you understand these forces and manage these forces properly through prosthetic intervention, then your outcome will be more predictable. Okay, and what do I mean by forces? I want to look at what's my opposing occlusion like. Is it natural dentition? Is it a denture? Is it a partial denture? What type of occlusal relationship am I dealing with? Is this an anterior open bite? Is it a deep bite? Deep bite automatically tells me that the patient has a lot of functional forces that pulls everything in, and there's a lot of lateral movement. Deep bite, for them to get out of that, it's going to put a lot of lateral forces on the anterior teeth. So lateral forces is my red flag when I look at cases like that. Does the patient have enough posterior support? I know the patient may be missing the anterior tooth, but there's no posterior teeth left. All their functioning is off the anterior teeth. That's another red flag. This is a case that the patient has a lot of forces on the remaining teeth. I need to protect my implant crown. I need to implement certain things in addition to my implant restoration. What's the occlusal plane like? Has the teeth shifted in a way that are unfavorable? I want to look at the whole picture, step back and look at these forces that may be detrimental to my implant restoration. I might need to recommend additional treatment to provide more stability to these dentition, to stabilize the forces, to protect my prosthesis in the future. So what I'm really thinking is, I'm thinking of a prosthetic design to counteract these destructive forces. Sometimes it's not just the implant crown, it's other things like restoring posterior support, stabilizing the anterior teeth. Maybe I need to do enamelplasty, adjusting the teeth on the opposing so that it's not putting a lot of unfavorable forces on the implant restoration. So that's one aspect that I always look at. That's part of my treatment planning. The other thing I look at is the aesthetic. Obviously, if I'm dealing with a posterior tooth that is not visible, it's not as important. But if I'm dealing with a visible area, like an anterior tooth, I always do a quick aesthetic evaluation. I want to see the smile. I want to see what's visible, what's not visible. Does the patient have a low smile line? Does the patient have a high smile line? What's the clinical crown height like on the adjacent teeth? Where's the gingival margin? Is there a lot of black triangle spaces? What's the overall width height proportion? Because that's going to, if I'm dealing with an anterior tooth, most likely the patient is going to start looking at the anterior teeth. And if there's anything I don't like on the existing teeth that's going to impact on my restoration, I like to highlight that now. And perhaps my treatment plan is not just one implant crown. Maybe the other teeth needs to be adjusted. Maybe they need crowns, veneers, bonding, whatever. So I talk about that because that's all part of my planning. I don't want to make excuses at the end. I want to identify those potential things at the beginning, again, to manage the patient's expectation. Okay. So I've stepped back and looked at the functional aspect of the case. I've stepped back and looked at the aesthetic aspect of the case. Truthfully, you still have to think about the patient, because you have a patient you're dealing with, right? So part of my consideration is my plan favorable in when I look at the patient's medical history. Does the patient have cost issue? What's the expectation? What are their wishes? Are there parafunctional habits? Those are the things that are patient specific. And so often I have to factor those in so that I can modify my plan appropriately. Okay, so basically, I just kind of walked through this roadmap with you guys very quickly, talking about some of the things that I have to think about when I'm planning for an implant crown or implant restoration for a patient. Truthfully, your process, my thought process is, yes, I would have evaluated a lot of that in my initial examination. But a lot of that may need further consultation with a surgeon. I might have to discuss with the patient a little bit more to come up with a plan that would work for that particular patient. So it's a thought process. Once you have done that, you will have a plan. And in my treatment plan, to me, there are 4 aspects. There's pre-surgical plan, the surgical treatment plan, the prosthetic treatment plan, and the maintenance plan. So once I have done all that figuring out, before you even start doing the dentistry, I would have a plan in my mind that has these 4 categories. What are some things I have to work out pre-surgically? What are the things that needs to be done surgically, even if you're not doing it, okay? What are the things that you have to do in the prosthetic plan? And what are the things I need to figure out afterwards that the patient needs to be aware of, okay? So that is really how I approach every implant case. You have a pre-surgical plan, a surgical plan, a prosthetic plan, and a maintenance plan. Okay. Now, I've talked a lot so far in theoretical terms, just to help you understand what all this process means. I want to use this case just to highlight the steps that I actually took from the beginning and to finishing the case. Okay. So this is a patient who had orthodontic surgery, had ortho that wasn't completed, then moved across Canada and didn't have the proper follow-up. And what happened was these 3 teeth had external root resorption and they're getting really loose. Actually, this tooth fell out already, and you can tell. So by the time she came to see me, this is the situation, okay? So you can see that at the end point, you can see she ended up having 3 implants, and this is the final restoration. But I wanted to just show you the steps I took from here to here, okay? We know that these 3 teeth will need to be removed. So pre-surgically, I had a cone beam CT. I also refer her to see a periodontist. So I had a radiographic referral for the cone beam CT along with a referral to see a periodontist. What we end up doing is looking at the bone, looking at the teeth. We decided we needed to remove 1-3, 1-1, and 2-1. We decided there's enough apical bone to consider immediate placement. And because she's going to be missing more teeth for now, what I planned was, at the time before she had the surgery, I had an Essex appliance made in advance. Okay, so this is all pre-surgical planning that needs to be done after consultation. Okay, so this is phase 2, the surgical treatment. You can see that I had a surgical guide designed and printed. So I sent this to the surgeon, and the periodontist removed those 3 teeth and immediately placed 3 implants with a healing abutment. And then she came back to see me so I can give her an Essex appliance so that it will allow time for these implants to also integrate. And at the same time, she won't be walking without missing front teeth. Okay, so after periods of healing, after 4 to 6 months of healing, then she's ready for the definitive prosthetic treatment, which is phase 3, which is what I provided for her. Okay, now those are the prosthetic steps that I ended up doing. Okay, but I just want you to know this is all the prosthetic treatment that is under phase 3. And once this case is finished, there's another phase that I want you to remember. There's the maintenance phase, because once it's inserted, this patient needs to be seen on a yearly visit to me so I can check the proximal contact, I can check the hygiene, I can check the occlusion. And if the patient cannot clean well, sometimes I have to remove the prosthesis to clean for the patient. So that's part of the maintenance plan for this patient. Going back to the prosthetic treatment, this is the prosthetic treatment that I undertake. So I took fixture level impression, I did a verification jig, I did a teeth try-in to confirm aesthetics. Then I made her a temporary implant bridge for several things, for soft tissue conditioning, and just to fine-tune the aesthetic and the functional evaluation, making sure the patient is happy before I make the final definitive restoration. So this is just the phase 3 of the prosthetic treatment plan. And this is the meat of what I do, obviously, but the planning in phase 1 is another aspect that I want you to realize. Before you can do this part, you have to plan it properly. The surgery has to happen before you can actually make the teeth. And once you make the teeth, there's a certain follow-up that needs to be included for the plan. Okay. So I just want to see how am I doing with time?
Yeah, you're good, I guess.
I'm good?
Yes. I mean, there's a question there. I don't know if the question is a little, I don't know if you got exactly what you were saying. Was asking, are there situations where you can use both screw and cement on the same crown? I guess you didn't quite understand what you were saying.
No, it's either a screw or a cement retained crown. They are now with the technology, I'm not sure if you're asking about screw-mentable, which is a technical, this is where I talk about the design material consideration. Basically, if you're looking at an implant crown, it's either a screw or a cement retained crown. You will have a screw to attach the abutment to the implant. You will have a screw, but the crown itself is cemented over the abutment. Okay. All right, so we're going to use screw and cement in the same crown. Yeah, I hope that answered your question, unless you were dealing with very awkward, unusual situation, but just to keep things simple, you either have a screw retained crown or a cement retained crown. Okay. Okay, so now that was just diagnosing. Now I wanted to talk about the delivery phase of treatment. And again, this roadmap that I have created for the course, it usually takes me about 2 to 3 days to complete, along with hands-on activities, right? But I wanted to really talk about the delivery sequence in detail, because that's where I see a lot of students struggling. However, without getting you lost in this roadmap, I have a case that I just want to show you how I work up the case properly. So here's the case. Okay, this is a patient that has implant placed in 3/6. Okay, now I've planned it. We have a discussion about it's going to be a screw retained crown. The tooth was fractured beyond repair, so it was extracted, it was healed, and then the periodontist later placed the implant. And I get the report back from the periodontist, it's ready for restoration. So this is where I want to show you how do I go from this step to finishing. Okay, so you have oftentimes I get a report back from the periodontist with an x-ray telling me this is ready to go, what type of implant, things like that. And so I review this report. Okay, but what I do in addition to reviewing the report is I just want to highlight the steps and the thinking process I have to plan the records, what type of components I need to order, what type of information I need to think about to actually order the components so I can take proper records. Okay, so you can see that this was pre-treatment. 3/6 had an endodontically treated tooth. The root was fractured, was beyond repair. So we end up extracting this tooth, and this was the arch, this was the occlusion. So I wanted to show you. Okay, so these are my pre-treatment record that I would have had before I send the patient off to referral. Okay, I don't always get this information, but if I do, it's useful information. So these are the things I look at. I evaluate, I have to look at the case, and before I don't go and start ordering components, because I have a certain way of looking at things and make sure that I order the right parts for the right case, because not all parts are equal in every case. Okay, so I wanted to show you what I look at. So I look at the brand, I look at the diameter of the implant, I look at the restorative platform. And that's what I talk a little bit about in my other courses before. Beware of platform switching, because a lot of people get burned in ordering parts that are not right, because we never had platform switching before, and now we have platform switching. And so sometimes people order the wrong parts. I look at the emergence profile to see what the tissue look like, how deep, how flared the tissue is created by the healing abutment. I look at the range of mouth opening. I look at where it is it anterior, is it posterior? I look at the arch form, and I look at all the undercut that might be critical for me to take the impression. Basically, I'm evaluating the case to help me determine what type of parts I need to order, whether I want to use a stock tray or a custom tray, whether I want to do analog impressions, or whether I want to do digital scanning. Okay, so what I've just wanted to show you is this case is actually a Straumann bone level implant. And when I look at the report, they put a 4.8 diameter implant. So it's one of the wider ones. But what you have to realize, even though it's a wider one, they have a restorative platform, which is RC, which is regular platform. And this is part of their platform switching design. So basically, you just have to make sure sometimes the diameter is not the important information. You wanted to know what the restorative platform, because they're not always equal, okay? Sometimes if you have an implant before the days that had platform switching, then the two numbers and they have the same meaning. But with platform switching, you could have RC of this restorative platform that are applicable to two different diameter implants. So without getting you guys too confused, this is probably too advanced information, but I just want you to make sure that diameter of implant does not always equal restorative platform because of the issue with platform switching. You want to order the right components that correspond to the restorative platform, not the diameter of the implant. I want to look at the healing abutment. In this case, they didn't tell me what healing abutment they used, but I look at the x-ray to kind of give me an idea. Is it flare? Is it straight up? And how deep it is, how deep the implant is, how much soft tissue thickness I'm dealing with. I want to look at the range of mouth opening, because when you start taking implant impression, you know you have to access the components, you have to screw. If the patients have very limited mouth opening, sometimes trying to access the screw can be challenging. So that sometimes influence whether I want to do an implant open tray impression or closed tray impression, or even digital scanning. Because if the patient can only open so much, you cannot scan, you cannot reach the posterior access screw easily, and that can be a very unpleasant experience for the patient. So these are more logistic issues that I look at, you know. I look at the area, is it the posterior area, is it the anterior area? Anterior area is usually a little bit easy to access. You can see it. Posterior area, if it's posterior, if it's a very limited range of opening, then sometimes I design my impression technique a little differently. I look at the arch form because that's going to help determine whether I want to use a stock tray or a custom tray. Okay, if I have a regular arch form that doesn't have very unstable up and down occlusal plane, if it's like a fairly average size arch form where I think a stock tray would be able to capture all the information, then that's the case. Maybe I want to use a stock tray. But if I have a patient who has a lot of edentulous span and a very uneven occlusal plane, I think my stock tray will not be able to capture all the teeth and all the information well. Then that's a case that I probably will need to use a custom tray for taking impression. Okay, I also want to look at how much undercut these I might have. And so the more you take impression on these cases, the more you start to look for things, because in the past, I've used a very rigid impression material like polyether. And so if you have a case that has a lot of undercut, which sometimes you do have patients with a lot of interproximal undercut, those cases, it can be a challenge to removing it. And so I wanted to see if this is a case I want to use digital scanning instead, okay? In some cases, depending on the position and angulation of the teeth, scanning is not easy, okay? And so I look at the overall case, I want to have an idea what I want to do, okay? So once I look at the case, I just ended up ordering an impression coping and an analog. In this case, you can tell that I order an impression coping that is for open tray, and that's a personal preference. I believe open tray is a little bit more accurate in my hands. And so I always aim for open tray whenever possible, unless the patient has very limited mouth opening where I might have trouble accessing the screw. Okay, so I ordered an open tray for crowns, which is what I end up doing. And I also order an analog at the same time. And that's because I find that I like to connect the analog myself at the time of the impression. That reduces the error. That comes from my time as a prosthodontic resident, where I used to pour up all my models. So I always take my impression, I attach the analog myself, and I pour the model. And that was something that I used to do for all the cases. But what I noticed when I first moved back to Toronto, the few cases I didn't do that, I find that there were errors, that the lab technician didn't connect to the analogs properly. And so from that point on, I always try to buy the analog myself and connect it myself. That tends to reduce the amount of human error that I see sometimes in the lab. Okay, so this is prosthetic components that I needed to order before I can see the patient. And so in this case, those are the questions I ask myself. What am I doing for the impression? So in this case, I am doing a fixture level impression of this implant. It's a Straumann RC implant. I decided to do open tray because to me that's more accurate. I decided to do stock tray in this case because I felt that the arch size is quite regular. I don't need to use a custom tray. I decided to use an analog impression instead of digital, only because the digital parts were back ordered at the time from Straumann. This case, I could have done a digital scan. There wasn't anything to me that would be a red flag to me that I think that I couldn't do a digital impression, but I decided to do analogs just because of the availability of the parts. And in my lecture, I talked about planning if this is a case where you need verification jig or whether you need to do a special jaw relation record, which is in this case, you don't need anything fancy because this is one tooth missing and there's it's a tooth supported space where there's posterior contact, anterior contact. You can properly hand articulate this case. It's a single implant. So I don't think I need to do anything special other than taking the impression. Okay, so once I order the parts, these are the steps I on the day of. The patient would have come in with a healing abutment. So I usually have a cup of ready with chlorhexidine. I have my driver where I would remove the healing abutment. I would put that into the chlorhexidine. When you remove it, sometimes I find that some dentists couldn't remove it because they're not used to the amount of pressure. They're afraid of removing it. Sometimes whoever tightened the healing abutment, even with finger pressure, I cannot loosen it. And so I use a torque wrench to apply counterclockwise torque to the healing abutment to remove it. Sometimes if there's a lot of soft tissue surrounding the healing abutment, like if the implant was placed quite deep, this movement of removing the healing abutment may cause discomfort for the patient and sometimes can cause a little bit of bleeding. So that's normal. And I see some students getting really scared when they see that. That's normal because you just kind of irritated the soft tissue. It doesn't mean that the implant is not working. It just means when you're removing the healing abutment, you're pinching the gum, you're pushing the gum, and that can be quite uncomfortable. It might feel like a little ticklish feeling, or sometimes it feels like a little pinching, and the patient will feel a little bit of discomfort, and they will tell you. And sometimes if it's so deep, I just ask the patient, if it's so uncomfortable, I can numb you up. And that will take care of the discomfort that you will see in these patients. Once I remove the healing abutment, I just want to take a look at what I see. I want to make sure I can see the implant platform. I want to see a healthy soft tissue. And sometimes what I'm looking for is, do I see a good keratinized tissue around this area? And so basically, I just want to see and make sure it looks fine. There may be a little bit of bleeding. If the patient's oral hygiene isn't great, you might see a little of a soft tissue deposit around the abutment or also on the adjacent teeth. Once I remove the healing abutment, then that's when you're going to attach the impression coping on the implant. And I usually take an X-ray to verify that it's fully seated. Okay, to me, in Canada, it's a legal documentation. So I always take an X-ray to make sure it's seated before I take the impression. Okay, now before I start taking the impression, I do a couple of more things. Because I am doing an impression with a stock tray, most likely I have to create an opening. In this case, because I ordered an open impression coping. So that means impression copings will have to come through the opening. Sometimes if you have asked for a custom tray, the lab would have sent you back a custom tray with an opening where the implant needs to be. So if I have a stock tray, I have to create an opening. Even if I have a custom tray, even if I have an opening, I try that in first. Because I wanted to make sure that I can position this tray in and out comfortably. I want to make sure I know how to move this tray or maneuver in a way in the mouth so that the access hole will come right through the opening with nothing binding on the edges. Okay, and that's when you find out, even if they have created an opening, this opening needs to be enlarged. And also, depending on how the teeth are positioned, you might have to kind of learn to maneuver the tray in a way to make sure that it's seated smoothly so that this opening, the access hole comes through the opening smoothly. You don't want to try to figure that out when the tray is loaded with impression material because you don't see and you're going to start panicking. Okay, so I always try to practice a few times before I put adhesive on, before I seal the access hole with the wax. So here, because you've created an opening, once you try that in, I will have to put a piece of roll wax or pink wax just to seal it so the impression material doesn't fall right through here. Okay, and also routinely put adhesive on so that the impression will stick to the tray. Okay, so the key thing is practice a few times to ensure a smooth transfer of the tray in and out of the mouth. And you want to make sure you can see the screw that comes through the wax, come through the opening. It shouldn't be binding on the holes. I find that most of the labs created these holes too small. So I find that I routinely have to enlarge it so that it will come in and out smoothly. I don't want it binding. Okay. The next thing is once the tray is ready, I just want to get the mouth ready. Few things I always do is if there's a lot of deposit around the adjacent teeth, I use a scale to remove it, clean the adjacent teeth really well. I still look at the other area. If I see the other teeth with a lot of these spaces, black triangle spaces, I tend to block it out because again, I used to use polyether a lot and that's very rigid material. And if you let the polyether flow underneath this material, it can be quite stiff to remove. Okay, so routinely, I do a check of the mouth, of the arch that I'm taking the impression. If I see a lot of, pontics, spaces undercut, I will block it out. You can block it out with wax, but I find that the wax can be displaced easily. And if moisture hits, so I usually use these leftover block-out resin from the bleaching kit. So I just kind of flow a little bit in the space, use my gloved finger just to wipe it so that it doesn't stick out, and then light cured it. Once you've taken the impression, either this will come out in the impression. If it doesn't, then I just use a scale to flick that out. So it tends to be a cleaner block-out material for me than wax or other block-out material that is available out in the market. Okay. But once you've done that, the rest of that is like just regular crown bridge impression. You will have to load the tray with your impression material. You will have to kind of use a syringe to load the material around the implant where the impression coping is. Obviously, you want to dry the area. There shouldn't be any saliva. The adjacent teeth should be clean, but you just want to capture this information. and seat the tray with the material timely so that you know that the access hole comes out through that opening. So this is an open tray impression technique, which is what I use most of the time. I find that that's more accurate. But that is a very timely, you got to move quickly. You want to make sure you syringe it correctly and blow the tray correctly and seat the tray correctly. Once you see the access hole coming through the wax, then I breathe, because I know I position it properly. You don't want to have a tray, position it, and you don't know where the access hole is, because then that is material setting and it's stuck, and it's not fun trying to find that access hole. And that's one of the things I think a lot of dentists preferred closed tray over open tray. But I do find that closed trays do have more human error incorporated in it than open tray, okay? So again, I usually have a whole lecture talking about differences between open tray and closed tray, but I don't have the time to talk about it here. But I just want to show you how I do an impression for an implant. So this is, once the material has set, then you will loosen the access hole so that you can take out the impression. Now, one of the things that I want to emphasize is I find that some students, they loosen the screw, but they don't loosen it enough, and they start removing the impression. And that is one of the errors I see. So one of the visual cue I want you to remember is you should be able to loosen the screw enough so the screw can slide up vertically, up and down. You don't have to remove the screw entirely, but you should see it moving. If you don't see it moving, then you haven't loosened the screw enough. And if you start removing the impression like that, you start ripping out the impression, which is not what you want. So you want to loosen the screw enough so that the impression can be removed successfully. Once I remove the impression, I immediately put back the healing abutment just so that the soft tissue doesn't collapse into the area. And when you do that, again, just want to remind you, you might see tissue blanching. If the implant is quite deep, there might be a bit of discomfort. So just want you to know, don't panic. It's just because the soft tissue is being kind of pinched a little bit while you're putting the healing abutment back. But evaluate the impression, and this is what I want to show. This is the part I always do myself. I always put the analog back on myself to minimize errors in the lab. So this is the impression that I would have taken. So basically for that case, I just want to show you, this is the impression I took. You can see I took it with a stock tray. I have the opposing model that I have to send to the lab. I did a jaw relation record, although if you look at the case, she might not need it, but I did it just so that the lab has some reference point so that they know how the patient articulate. And finally, I have the shade. So for a single tooth analog impression appointment, these are the things I want to make sure I have to be sent to the lab. I have the final impression model. I have the opposing model that's already poured up. I have the jaw relation record. You might not need it if you think you can hand articulate it, and have a shade. Okay. And so this is a laboratory prescription that I've prepared for the patient to be sent to the lab. So I sent all that to the lab. And then this is what I get back. Okay. So this is the part where I'm going to spend a little bit more time just kind of figuring out some of the challenges that you might find yourself when you're trying in this implant crown. Okay, so first of all, when I get this case back from the lab, before I have the patient in the mouth, before I have the patient in the chair, I try this on the model. Okay, it's important, especially if you're new to doing implant, because you want to have some reference point. You want to have an idea of some of the challenges you might see. So I usually encourage you to do a preclinical crown evaluation. And one of the things I check, I want to make sure it's seated. I want to check to see what type of proximal contact I have on the model. And I just want to make sure the occlusal relationship is adequate. Okay, so these are the things that I usually like to see. So I get the crown back, I have the model, and then the model often will have the implant analog there. And then there's usually a piece of soft tissue moulage that is surrounding the implant, okay? And this can be removed, so you can see that. So what I usually do is I put the implant crown on this implant model. I wanted to see how it seats on the implant. Here you can see this is seated. Here you can see this is not seated. I mean, sorry, this is seated. This is not seated because you can see a gap, okay? And what I want to see is when it's seated, I wanted to compare the marginal ridge to the adjacent teeth. When it's not seated, you can totally see the marginal ridges are higher than the adjacent teeth, right? I also wanted to have an idea of how tight this is on the adjacent teeth, okay? If it's open, you know you've got an issue. You've got an open contact, but if it's too tight, it's binding a lot, that's going to tell me that it's going to have a similar situation in the mouth. But if it goes in, it looks like there's not a lot of binding, then your proximal contact may be very close to perfect. I also wanted to see how much resistance I have. If you look at this piece of soft tissue moulage, it's beat up or it's missing, or when you try to put this back in, you have a hard time putting this crown onto the implant because all this little soft tissue rubber gets in your way. That's a clue that when you actually try this in real life, you're going to have a lot of soft tissue interference. So that's something that, you know, with experience, I automatically know what to expect. But for someone who hasn't done enough implant crowns, this is like your trial run to anticipate some of the things that you have to encounter. And it's a good idea to have that reference point. You want to make sure that, oh, you know, when it's fully seated, the marginal ridge should be at the same level. That gives you a visual cue, because when you start struggling in the mouth trying to get the implant crown seated, if you see the marginal ridge is raised, you know that you haven't gotten seated if the model is correct, okay? And if you feel that the proximal contact is tight here, the proximal contact is probably going to be even tighter in real life. And if you see you get a lot of soft tissue interference from the rubber, piece of rubber here, you're going to get a lot of soft tissue interference as well. So those are preclinical crown evaluation. I think it's good for you to look for before you actually go into the patient's mouth, okay? Now, when you have the patient in the chair, this is my checklist of the things I check for in this particular order when I try in the crown, okay? And so you'll see the first item is the proximal contact. You have to check the proximal contact, and this is where I find a lot of people have trouble getting the implant crown to be seated, okay? You know, the students at the University of Toronto, I can't seat the crown, the contact is too tight, it's too tight, or the soft tissue is interfering. So when you get a crown back from the lab, it's not like a slam dunk kind of situation where you remove the healing abutment, it just goes in. If it goes in just like without any effort, that's great, perfect, it's a good experience for you. But if you don't panic. But those the things that you have to look for. So there are three things I want to talk about when you can't seat the implant crown. First thing is interproximal contour. The other thing is the soft tissue and hard tissue contour that might preventing the crown to be seated. And the third thing I'm going to talk about is the anti-rotational element of your implant crown abutment connection. Okay, so I'm going to talk about the interproximal contour, which is really a proximal contact. Okay, I find that dentists, when they do crowns, they get away with a tighter interproximal contact because teeth have ligaments. So they give a little bit. So even if the crown is a little tight, with a little bit of pressure, just force it in. It might be a little bit tight because you have the ligament will kind of, you know, readjust itself and you'll get away with it. Okay. But with implant crown, if you have a tight interproximal contact, it won't go in because implant is very stiff. There's no ligament in it. And so you really have to learn how to adjust interproximal contact properly. Okay, so a couple of scenarios. If it goes in really easily, that's great. You're done, you can move on to the next thing, take an x-ray, okay? But if you're struggling at this point, don't panic, but you have to learn how to adjust the proximal contact. Okay, couple of things, either it goes in or it doesn't go in. If it doesn't go in, that means your interproximal is tight. If it goes in, take a radiograph. You can move on to the next thing. But if it doesn't go in, you have to learn how to identify where to adjust. And that's where I see a lot of people don't know how to do that. And they keep on trying to force it in. Again, you can get away with that with tooth crowns. With implant crown, you get into trouble if you try to force it in. Okay. So you have to adjust the proximal contact because it's too tight. You have to adjust it until it's fully seated. Okay. How do you know where to adjust? Okay. So this is just something I show my students, just because at the dental school, this is all we have. We don't have any fancy material, but you use an articulating paper. Normally the articulating paper is too big. So I might have to trim it so that it is just occluso-gingivally tall enough to cover the proximal height, and also mesial-distally, it's long enough so I can grab it with my finger so it's tight. It has to be tight, otherwise it won't mark, okay? So you wanted to kind of hold it like that. That's how I do it. I find that it's probably easier. And you have to make sure the area is not moist, it's not wet. The tooth and the implant site, if there's any saliva, dry it up, air dry the area so you've got a dry interproximal contact so that you can pick up the articulating mark. Okay, so try to seat it while you're holding it like that. Okay, so this is a video that just showing you, I hold it, I push it up and down vertically. Now here you can see that it's seated, but even if you cannot get it seated, what you're trying to do is trying to rub the proximal area so that you identify the area that's preventing it from seating properly. And you have to adjust that area, okay? So you're trying to identify the interfering surface so it can be adjusted so the crown can go in further and further in, okay? You have to learn how to adjust that. Now, articulating paper gets really messy sometimes, especially with the saliva and everything getting in the way. So I just want to share with you a few tips that I sometimes tell the students to do. Is I actually find PIP paste a little bit easier. It doesn't flow. It does get messy, but I can see it with a pinpoint where it's much, the marking is removed. And so that's where I adjust it. But also there are products out there where it's like a brush on paint on the crown, so that wherever it is, the color is removed, that's where you have to adjust it. But another trick that is, if you use dry eraser marker, the non-toxic, non-odor one, that can be an easy one to do. You just kind of mark the proximal contact with the color, and you kind of put it on the implant crown, on the implant, and wherever it's rubbing, wherever the color is gone, that's where you have to adjust it. So adjust it a little bit at a time until it goes in. If you over adjust, you lose the contact, which is not good. So this is the area where you need to have a little bit of patience. You can't rush it, okay? So this is an example with articulating paper where you can see that it's marked off with articulating paper. So I remove all of the blue mark if I cannot get it seated, okay? So I repeat that until I can get it seated, until I can floss through the area with a snap, okay? If I get it seated, but the floss is shredding, so then I start removing only part of the mark, okay? Basically what I'm trying to change is from concave contact to a point or convex contact, okay? So where do I remove on this mark? I don't want to remove everything because I don't want to lose the contact. Is really just coming from you understanding where the ideal proximal contact should be. So basically, I usually try to divide up the proximal surface into thirds: occlusal third, middle third, gingival third, and buccally, middle, and lingually. We know that most of the contact should lie on the occlusal third, along more on the buccal aspect. So usually, if I see something like that, this is the area where I would remove my marking and to maintain that. So then the floss will hopefully not shred and become a snap. So oftentimes when I get to the point where I can finally floss through it, but it's shredding the floss, you're almost there. You still need to refine that contact. And this is where I would try to look at where the contact is and remove part of it. So the surface area is now down to one, maybe point contact or a smaller surface area. Okay, what do? I use usually stone to remove contact. I find that diamond burrs too aggressive and it can lead to an open contact. So I usually use a heatless stone or just these green stones to remove the contact enough until it's seated, and then I polish it off. Okay, so that is usually the hardest thing I find that students struggle. They can't get it seated. They don't know how to adjust the proximal contact, where forcing used to be the solution to deal with tooth crowns, but when you have an implant crown, that gets more challenging. Okay, so if the proximal contact does not look like it's too tight and you're still struggling to get it seated, the next thing I look at is the soft and hard tissue contour. Okay, sometimes it's just soft tissue alone. Sometimes it's soft tissue and hard tissue. Okay, and so you have to know how to tell the difference. Some clues to look for when you look at an implant. If the implant is placed quite deep below the prostobone, you know, you imagine this is the healing abutment. So the soft tissue is now kind of hugging like a turtleneck around this healing abutment. But when you have an implant crown where you have the emergence profile that is not the same as the healing abutment, you can imagine when you remove this healing abutment, even if you have the ideal proximal contact, this part of the emergence profile of the abutment is going to push the tissue laterally. And if the tissue is deep and thick, you're going to have soft tissue interference. You're going to feel like you're fighting with soft tissue to get it seated. So when you try to force it in, you will find that the tissue might be blanching, and the tissue will look at you. The patient will look at you, oh, this is not comfortable. So I usually will tell the patient in advance, you know, you're going to feel a little bit pinching around the gum. If it gets so uncomfortable, I will give you a little bit of freezing. Okay, but that's how you can tell. When you look at the healing abutment, you look at the restorative abutment, they're completely two different shapes. You can bet on the fact that when I insert this crown, you're going to have tissue blanching. It's going to be uncomfortable unless you numb up the patient. Okay, so it's different, and you know that you're going to have soft tissue interference. If it's really just soft tissue interference, depending on how much you can push, you know, and you will be able to seat the crown. And some people are a little shy. I find that some students are just, oh, you know, they are uncomfortable. And so, but usually my experience, if it's soft tissue interference, I can get it to be seated, but you will be fighting with the soft tissue. You might have to numb up the patient, okay? And that's where, you know, if you look at the current literature, people encourage you to use custom healing abutment to more customize the soft tissue contour so you don't have this issue, okay? That's another day for the lecture like that. But, you know, if you're using a stock healing abutment and then the gingival emergence, the emergence profile of your implant crown is very flare, you will get soft tissue interference, but you should be able to seat it if you kind of engage it and push it hard enough. If you do have hard tissue interference, that's where the trouble is, okay? So this, if you look at this implant, you can see there's a lot of bone around this above the fixture level of the implant. Even though you have a healing abutment seated, the gingival, the emergence profile of the implant restoration was wide enough that the implant crown was not seated, the dentist was not able to seat the implant crown at all. Okay, you can see there's a lot of crestal bone right here. So in this case, you will not be able to seat the implant crown at all unless you remove some bone. Now, this is more common now. You know, 20 years ago, I never see these kind of situations because we used to place everything at bone level. But now the movement is, if you look at the literature, everyone says you need to place at least 4 millimeters below the gingival tissue to have certain biological width. Or patients who are, or dentists who are doing immediate placement of implants, where they tend to place the implant deeper to have apical engagement to get primary stability. So when you place the implant, you place it deep enough, you're able to place a healing abutment. But then when the bone, when it's ready for restoration, you have too much bone in the area that hasn't been removed and contoured properly for the restoration. And that's where I see a lot of challenges in from the restorative end. The dentist couldn't recognize it, they couldn't see it, they were fighting, they take impression multiple times, then they will finally realize that the surgeon needs to actually remove some bone. Okay, so you will not be able to put the implant crown on if there's bony interference. You will not be able to see it. Okay, so I just want to show you, this is a case. The dentist sent it back to me because he couldn't insert the crown multiple times. He had scanned it, he had taken the impression, he placed it himself. He said he used a guide and there's primary stability, but you can see there's a little bit of bone surrounding it. Okay, so by the time I saw this patient, I actually have to flap this. I have to remove a little bit of bone, so you can see this is more flared out now. And finally, I'm able to make her a new implant crown so it's seated. Okay. So for bony interference, you will not be able to seat the crown. You will get both soft and hard tissue resistance, okay? And you will not be able to seat it. And the only way you can tell is by looking at the x-ray, seeing the peak of bone that is still above the fixture level. Okay. So proximal contacts is usually the area where it will prevent you from seating the crown. And if you have an implant that is placed very deep subosseously, soft tissue interference is what you can anticipate. But if you also have a peak of bone that is kind of left at the time of placement of implant, and your emergence profile of the implant abutment is too flared, you will not be able to seat the implant crown. You need to send it back to the surgeon to remove that bit of bone before you can seat it back. Okay. The third thing I wanted to talk about when you're inserting the implant crown that you have to understand is that for single unit crown, the implant abutment needs to engage the anti-rotational element of the implant. And so what do I mean by that? When you look at an implant, the implant, depending on what type of implant, even if it's external hex, internal connection, this is a Nobel bowel care trilobe. You can see this is a triangle shape. You can see inside this implant is internal hex shape. We call this conical connection. So all these abutments, if it's a single unit abutment, they need to engage part of these feature, okay? Such that even if you have no screw coming through these abutment, when the abutment is seated on this implant, it will not be able to rotate because the shape of this abutment engages the internal hex of this implant. So you cannot rotate this implant, this crown, this abutment. If this is a trilobe, this replace leg, these little extra lobes on the abutment, it engages here so that when you put the abutment on this implant, the implant abutment will not be able to rotate even if you have no screw. Okay, even for the external hex, it may not have as much of an engagement, but it's designed so that the abutment interface on this area engages this hex, so it will not be able to rotate. And that's what I meant when I talk about the anti-rotational element of the abutment. Okay, for single unit implant restoration, the abutment is always engaging. For splinted restoration, it does not have to be engaging. So when you look at the abutment, okay, both of these abutments are Nobel bowel care, UCLA type Go-Adapt abutment. One is called engaging, one is not engaging. The top portion is exactly the same, but the bottom portion is where the difference is. This is designed to engage the conical connection, the internal hex of the implant. This is not. Okay, so you have to understand when you're dealing with single unit, They always have to have that, okay? For single unit, you need anti-rotational feature to engage, so they use engaging component. So that not just the screw is securing the abutment, but this part of this will prevent the restoration from rotating. Whereas when you have a splinted restoration, they don't need it, because by virtue of a splinted design, you have two screws, two components, you have a built-in anti-rotational element. And so the abutment they select often will not have this engaging feature, okay? So that's important for you to understand, because it makes inserting a splinted restoration a lot easier, okay? Whereas when you're actually inserting a single unit restoration, it can be quite challenging if you don't understand that, okay? So this is an implant crown of a Straumann at, and this is a tissue level wide neck with a sing octotype connection. If you look at it carefully enough, it actually looks like an octagon. Okay, and this is the anti-rotational feature of the abutment of this particular implant. Okay, so oftentimes before I insert the case, I want to feel this connection. I want to see it. I want to feel it so I can know what to expect. So it's a tactile sense. So sometimes if you don't know what to look for, you don't realize it's there. So that's why I wanted to point that out. So what I'm doing, this is just an implant analog. Just want to see it's like an octagon. And then I have the crown. I'm looking at the integral surface, looking at the anti-rotational element of the implant crown. And you notice there's no screws right now, okay? There's no screws, but when I go in, you see how there's a little click. And when it clicks, without me holding the crown, it doesn't fall off my analog, because it's engaging the anti-rotational element. So I want you guys to understand that when you're dealing with single unit, you have to understand there is an anti-rotational element that needs to engage the implant. So what does that mean? So I use this little toy to help you understand when you're inserting an implant crown, a single unit, it's like you putting a block through these little holes. When you don't just kind of jam it through the hole, you have to make sure the edges are lined up, right? So in the same way, when you're inserting the implant crown, you're not just inserting it into the gingival direction. You actually sometimes have to rotate a little bit, slightly, so that the edges line up. And once the edges line up, then it will drop right into the implant. You will feel that click. Okay, sometimes the click is more evident when it's above the gum. If it's if there's a thick tissue, you might not feel it, but you will feel the movement. You'll feel the little rotation. It drop a little bit more. That little drop is what gives you confirmation that you've engaged the implant abutment correctly. Okay, so as a summary, you know, when you're inserting an implant crown, make sure you check the proximal contact. If it's tight, you have to take the time to adjust it. Don't force it in. You're going to get in trouble. Okay. Check for the soft tissue interference. Look at the model. See how much it bounces up and down. This soft tissue interference that you're feeling is likely going to be the same type of soft tissue interference you're going to encounter. If it's truly soft tissue, you should be able to seat the crown. You'll see the tissue blanching a little bit. The patient might feel a little bit uncomfortable, but you should be able to seat it. If you cannot seat it, start looking for maybe it's bony interference, which means you need to remove some bone. There's no way you can get it seated. Okay. And then the last thing is understand the anti-rotational element, the click, how you have to feel the little click. Okay, so you have to kind of feel it click in. Once it's seated, it won't fall out even if there's no screw. Okay, now in reality, if it's that soft tissue, the soft tissue will actually push it up. But once you get it seated, you feel it drop, you hold it down and you tighten the screw to keep it down. Okay, so those are the 3 common things I see. students struggling, dentists getting stuck, not knowing what to do because they couldn't seat it, or they don't know how to adjust the proximal contact. Okay, so again, so that's a lot of information, a lot of detailed information that I wanted to share with you. If it's your first implant crown or you've struggled before, hopefully you know what I'm talking about. I'm just going to talk about a little bit about occlusion, because that's another area where I see people getting into trouble. So once you get it seated, like I said, check the fit, take an x-ray, make sure it's seated. The proximal contact should be correct, you know, and that usually takes a good portion of my time, okay? So if I'm struggling to insert in the crown, it's usually at this stage. Once everything is done, the rest of it is very quickly done. So, but one thing, if you've done enough of it, it's easy, but if you haven't done enough of it, then those are the things that you have to look for. The thing I want you to understand is you have to know how to adjust the occlusion for the implant crown. Okay, because if you don't adjust the implant the occlusion properly, then you're not managing the forces properly, and it's going to come back and bite you. Okay, if you don't adjust the proximal contact properly, you've got too much interproximal forces, it's going to lead to some prosthetic complication. If your occlusion is not adjusted correctly, it also will come back to with prosthetic complication, probably screw loosening and teeth shifting. Okay, so basically, one thing I want you to remember is when you're looking at an implant crown is not a tooth. An implant crown has no periodontal ligament. Okay, so if you leave a crown slightly high in occlusion, most likely the tooth will adjust itself because you have the periodontal ligament. Okay, but if you leave the crown a little too high in occlusion, you have no periodontal ligament as your buffer, you might end up putting too much stress on the implant abutment interface and can give you problem. Okay, so for that reason, because we don't have the periodontal ligament as a cushion, we tend to establish occlusal contact differently on an implant crown than a tooth crown. And one of them is to make sure that the implant crown has very light occlusal contact. And by that, the way we define light occlusal contact is we usually use a shim stock to quantify how much contact you can establish. So usually the way we identify is if you have shim stock type contact on occlusal contact on natural teeth, where you put shim stock, it's tight, you can't pull out. Basically, when you have an implant crown, when the patient closes, when you put the pieces of shim stock on the occlusal surface of the implant crown, you want to be able to pull it out. So basically, you don't want so tight occlusal contact that it rips my shim stock. You want to be able to adjust the occlusion so that the shim stock can come through when the patient is in occlusion. So that's how we define light occlusal contact. The other thing I wanted to look at is you can see that how I have two circles drawn onto this occlusal table of this implant crown. Okay. Anything else inside the green circle is an area where it's directly underneath the supposedly implant diameter. Okay, so when I look at the occlusal contact, once I get it to be adjusted so that it comes right through, so the shim stock is not stuck in the occlusal contact, then I look at the location and the distribution of my marking. If my occlusal contact are within my green circle inside, that means my occlusal contact are directly axially loaded. That means all the forces are directly above my implant. If I have occlusal contact that are outside my green circle, but inside my red circle, so if it's a natural tooth, it's not going to be as important because you have roots to support it. But here, when I have occlusal contact outside my green circle and inside my red circle, to me, those are potentially cantilevering occlusal forces. And so for that reason, sometimes I eliminate those occlusal contact if I have a patient with parafunctional habits, okay? It's not something I always follow. It depends on the patient, but I look at these things because I don't want, if I have a big occlusal table, a small diameter implant, then anything outside my green circle, I tend to try to eliminate because I don't want to introduce a lot of cantilevering forces on my implant crown, okay? And so that is when the patient is going into centric closure. When the patient closes, make sure the shim stock can be pulled out all the way. I look at the location distribution and make sure that if it's a big occlusal table, I try to limit my occlusal contact to closer to the implant so that it's not as much of a cantilevering forces. The thing I also look at is my excursive contact. Ideally, I don't want to have any excursive contacts like working contact, protrusive contact, excursive contact. I want to eliminate all that together. Okay, so when I ask the patient to kind of move side to side, front and back, all those occlusal contacts I want to eliminate because those are unfavorable forces on the implant crown. When it comes to the anterior teeth though, sometimes it's a little difficult to do that because part of it is guided by aesthetics, right? So if the incisal edges is such a way that I feel that, you know, it's going to be hard to eliminate these protrusive or excursive contact altogether. At minimum, I want to make sure that it's shared between my natural teeth and the implant crown. So basically, I want to make sure that when the patient is gliding side to side and front and back, the patient is not gliding off my implant crown. I want to eliminate altogether if I can. If it's not possible, I want to make sure that is at least shared between my natural teeth. Okay. So that I just put this here so that, you know, this is a part of the paragraph I got from this textbook, Fundamentals of Occlusion, which was published by the American College of Prosthodontics. And so this just sums up everything that you need to understand when it's implant related occlusion. What is an implant ideal protected occlusal scheme? Not too tight a proximal contact. You want to make sure that you can pull the shim stock through so it's not loaded excessively. You want to reduce the occlusal table so that there's less cantilevering forces. You want to make sure there's not a lot of excursive or protrusive contact on the restoration. You want to eliminate that whenever possible. Okay. And so that is checking occlusion. The rest of it, I'm not going to go in detail, but that is what I look for. Check the contour, color. Once you're happy with everything, then you can torque the screw, you can seal the access hold, and review post-insert care. So this is just part of what I talk about in my course, which is usually a 2 to 3 days course, combined with some hands-on. I went into very detail about the insertion protocol because that's where I usually see a lot of people getting into trouble. Okay. How am I doing with time, Ivo?
We are, yeah, so we are we are almost there. I mean, we have a couple of questions already out, but how
so
much?
Maybe I should stop here. You think that's a good idea? Because next I'm going to talk about, I know you want me to talk about temporary, but I just think it's information overload.
Yeah.
I don't know.
Maybe we can, are you able to do it another time so we can take the questions? Yeah. Okay. All right. Thank you so much. We have about maybe like 7 questions. So let me see. Okay. So the first one, you see the first one by Yadashi Alemu. It was asking about how much time do you need?
How much time do you need between extracting the teeth and screwing
placing the implant? I guess maybe
placing the implant. So in my book, it's if I am doing stage, which is another area that I talk about in the course. You know, how do you figure out the timing? If I am extracting the tooth, I would like to evaluate the area in 8 to 12 weeks, which is equivalent to 2 to 3 months, which usually where soft tissue and hard tissue will start to mature. I'm going to say for a small tooth like a premolar, that is probably good enough. For a molar site, because of the big roots, sometimes you need a good 6 months. So it's a very difficult area to judge. So you don't want to wait too long, because sometimes you wait too long, you lose too much bone. If you don't wait long enough, you end up getting granulation tissue, you can get primary stability, right? So it's a fine line. Also, it depends whether you did bone grafting or not, right? If I did bone grafting, I usually would like to wait at least 6 months. Okay, but if it's a premolar anterior area, I will probably revisit the area in about three months. Just make sure if it is adequate. The key is you wanted to take an X-ray at that point, and what I look for is I want to see if I can see the lamina dura. If I see that, I can start to see that the bone filling in, I don't see the lamina dura, that means the bone is filling, right? If you can still see a distinct socket in the X-ray, then it may not be ready. Okay.
Okay.
So the other question is, you talk about some person not liking the screw retained crown because of the opening. Can't we close the opening of the screen with composite? Yes. So sometimes we get very picky patients. So we routinely close the screw access with composite resin. However, sometimes if it still leaves a little bit of a different color to it, and some people don't like it. Okay, so it is really like a root canal treated tooth, but I've had patients, they look at it and like, I don't like it. And so there have been talks about how to hide it. Now that we're using zirconia crown, we don't see the access hole as easily, but in the past, what we've done was we use PFM. And so the screw access, the channel is actually metal. And so when you actually seal it with composite, you still see a little bit of a gray over it. And so some people consider that anesthetic. I've heard other people using Teflon tape to hide that a little bit, and they have had good success to seal the access hole. But I have had patients that they find that it's not, they didn't like seeing the opening. And so, and if that is an issue, then that's where initially when you plan it, you wanted to do a cement crown, maybe that may be a better option. But I don't get a lot of that, but I like to identify those people early on so that when I plan it, I plan the right design for that patient.
Okay.
Concerning the patient who had a fixed replacement of 3 teeth, including the pink portion to restore the soft tissue, I'm assuming it's fixed because you mentioned removal of cleaning. Is yearly sufficient? I think the foot debris plaque would get trapped. Why wasn't an implant retained RPD considered instead? In this case, yes, once a year will be sufficient, and the patient actually can clean quite well. So I don't think I actually remove that at all. But there are some patients whose implants were planned without very good prosthetic planning, and we have a situation where a patient who wants fixed only and don't want removable, and we end up having to do a compromise to do a fixed solution, but with the understanding that the implant bridge needs to be removed for cleaning. So the case I show in this presentation, it doesn't need to be removed regularly because it's positioned such that it's can be cleaned by the patient. But I've had situations where the implants were placed in a way where if I have to provide a more aesthetic solution, it's going to create a big ridge lab, which is not cleansable, and the patient cannot clean it, and I have to remove it for the patient. Why wasn't an implant retained RPD considered? It was if the implant was placed non-ideally, that would be an discussion I would have had. But I find that a lot of people cannot accept an implant retained RPD. And so after discussion, we end up going fixed. So that's why I spend so much time talking about planning, because a lot of these complications starts from inadequate planning. Inadequate planning of what needs to be done, what is expected from the patient. And if you actually take the time to have proper patient management, a lot of these issues would have been solved. Okay. Are there available implant systems that have both screw and cement options? Most of them have both screw and cement options. It's you, the dentist, who have to tell the surgeon what you're aiming for. Now, most of us now are designing for screw retain just because we're seeing a lot of complications for cement restoration. But I'm going to say 20 years ago, when I first graduated, we were talking about how to plan positioning for a cement option. There were issues where, they believed that the implant frame would not ever be passive if it's not cementable. And so that was all, 20 years ago. So, but now, like I said, most of us believe screw retain is better because you don't have cement. However, I do find that in general, dentists still prefer cement retain because it's more familiar with them. So even though I have told some of my classmates I would do a screw retain, they end up doing cement retain. So I think it's also the comfort level of the dentist himself. So most of the system out there are designed for both. It's you, the dentist, who have to decide which system, which design to use so that you can place it properly and so you can restore it properly. How can you decide the length and the flare of the healing abutment? So at the time of the placement or at the time of uncovery, you look at the soft tissue thickness and the intended restoration. There's no strict rule, but I find that, if it's anterior tooth that my anticipated crown is going to be much wider than my implant, I would like to do a more flare healing abutment. But also, if this is an area where there's not a lot of keratinized tissue, I find that the surgeon likes to use non-flare healing abutment to preserve as much keratinized tissue as possible. I find that if the surgeon uses a straight healing abutment, the restorative dentist can't manage the flare of the restoration. And so that's where you see the movement where they want to customize the healing abutment so that there's less resistance at the time of the insertion of the implant crown should the emergence profile be significantly different from a stock healing abutment. Okay. As there is no implantology lecture in our country, Ethiopia, is there any possibility to attend on-site practical lecture abroad or any meeting abroad? Please let us know if it will be helpful for us as a student from Ethiopia. That's why I talk about my this implant course that I'm doing, because I'm not administering it, but I'm just creating the content. But I think if you guys really wanted to learn, we have these courses with hands-on that are open to people attending. If you guys are interested, I would definitely let my classmate Sanjay know, because I told him we're looking at offering it outside of Ontario. We're first now looking at outside of the province, but if there's a need, we will look at bringing this program to other countries, or we are open to registration from other applicants if you are willing to fly abroad to where it's offered. So definitely, if you are interested, let us know.
I was gonna, that jumped on my, I want to invite you to Africa.
Oh.
So we do have some hands-on session planned, and there's going to be an implant masterclass. So it's not just for every, because this is going to be a little more detailed, and obviously there's going to be a fee attached to it, so that we can get people. So we are planning implant masterclass, and I would like for you to. I guess I'll talk to you about it later on. But
yeah, definitely.
My friend from Ethiopia, I'm going to be in Ethiopia in November, and we're going to do some sessions. It's not going to be as detailed as the one that Dr. Leung does. I see it online. I'm like, wow, you need a lot of just the equipment. You need a lot of equipment, you need a lot of supplies, and that is another level. But in terms of just the preliminary, just basics stuff that you need to learn, even as a student, we are coming to Ethiopia. If you have money to fly to Canada, please let me know at the end of this lecture. Somebody send me a mail and we can plan it. I mean, the lectures are held ever so often now. You can also plan to be there. Yeah.
Okay. If a patient has an implant and needs an orthodontic treatment, how do we apply? Great question. It really needs coordination. So what you were, there are two things, okay? There are some implants are just designed for orthodontic treatment and for anchorage, okay? So that in terms of placement, it doesn't have to be at the place where the implant needs to be. But if you're planning to use the same implant to provide orthodontic anchorage and to be used later for restoration, that needs a lot of planning, very, very advanced planning. So great question. You can do that. It's not easy, okay? Why do a lot of patients who've had implant have signs, symptoms like back, headache? What do you think the cause of implant failure is? Because problem with osseointegration is sensitive to metals. Okay, so if I have a patient who have an implant, I don't expect to have pain, okay, or headache. So if it's an implant that is integrated, I don't expect to have pain. If there is pain, there's possibly soft tissue integration. There's not true bony integration. That I expect that even though it's stable, there's something I don't like about the implant. Okay, if that's the case, this is what I would tell the patient. You know, it's stable, but you're having sensation, which is not normal. So like 95% of my implant, there's no sensation. Okay, if there's sensation, that means there is not true osseointegration. You've got soft tissue integration around the implant. If it's bad enough, then you need to remove it and redo it. That's what it takes, okay? I see a lot of patients who's not ready to take that step and they're stuck in that stage, okay? In terms of back pain and headache, I don't think it's related to the implant. These are symptoms to me as a prosthodontist. I think it's more related to occlusion. Although, Ivo, you probably know, this is a very controversial topic.
Yes.
I don't want to confuse people. Pain and headache, to me, I think there's occlusion component to it. So maybe you're dealing with just one missing tooth, but I think the whole occlusion complex is not stable. So it's imbalanced, giving off these signals to the body. And so I don't think it has to do with integration. I think it has to do with other issues in the mouth that we haven't addressed yet. Okay,
nice. There's some questions in the chat section.
Okay. Oh my goodness. Okay, so where do I start?
Yeah, just start from the last one. The last one that's on there.
Good evening. Please, does food not pack in the access hole of the screw? No, the screw access hole is supposed to be closed yeah, with either cotton pellet or Teflon tape first as the layer, as the base layer, and on top of that composite resin. So you shouldn't have food getting stuck in that access hole. Okay, please type this. How can you decide?
That question has been answered. So the next one is one from Anthony, which says, is there a specific diagnostic criteria guiding implant prosthetic planning?
Oh, okay. So thanks for clear treatment plan. Is there a specific diagnostic criteria guiding implant prosthetic? So I do talk about my pre-prosthetic evaluation. I didn't talk about in detail in this presentation, but before I start ordering components, once you've planned it, you know, if you're not the one doing the surgery, sometimes once you get the report back, there's a certain process I go through, you know, has the implant osseointegrated? So those criteria that maybe that's what you're specifically looking for is absence of symptoms, no pain, no discomfort, X-ray radiographically, you like the bone level, okay? And also soft tissue wise, you like that there's adequate soft tissue surrounding the implant, okay? So that is the clinical information I look for. Now, in addition to that, now I start doing is when I get the implant back, I remove the healing abutment and I test the implant stability using a penguin or an instability test. So that's in addition, just to make sure that the implant is healed up. And basically it spits out, it does it by radio frequency, it spits out a number. The higher the number, the more stable it is. If it's a low number, I have to make two decisions. Is it ready to be restored? Do I wait longer? If I'm going to restore it, maybe I intentionally leave it unloaded, okay? But yeah, there is a diagnostic criteria that most people will go by, which is, you know, absence of pain, discomfort, adequate level of bone level, good soft tissue, and it's stable clinically, like it's not spinning, right? So I used to use a healing abutment. When I put a healing abutment, it's tight, it's not spinning, but that's a clinical evaluation that is not quantified. So now with the implant testing stability tool, I use that to quantify that. Some surgeons sometimes will send you that report, will tell you this is ready for restoration. This is also the number, so it's ready to be restored. On top of that clinical evaluation, I recheck the positioning and the angulation of the implant to make sure that it's consistent with my original restorative plan. Because sometimes things can go different direction, right? Even if you plan it, it doesn't come out how you plan it. And if it's so off from our original restorative plan, again, I will talk about the expectation again. I can restore it as is. What are the advantages, disadvantages? Really, it usually means hygiene, aesthetic, functional, all that maybe not be ideal. Or if it's bad enough, I remove that. I ask this implant to be redone, which a lot of people won't like to do that. But that is really a checklist that I do with my patient before I start restoring the case. Okay.
Okay. Well, one last question here about impression technique.
Does the impression technique vary with whether you plan to use cemented or no? Whether you do screw or cemented, it doesn't change. What I find, the techniques, it's a personal preference. For single units, you can use open tray, you can use closed tray, you can also do a digital scan. But personally, I find that I have more human error when I do closed tray, because I find that the lab technician sometimes doesn't position it back to the impression exactly the same way. I find that I see more errors, so I tend to avoid closed tray technique whenever possible. So it's really between open tray versus digital scanning. And then that becomes, you know, is the patient a gagger? What are the undercut? Is it easy to scan? What's the range of opening? So all those things will influence my decision. And also if I can get the parts on time, right? So those are decisions that those are factors I think about before I make a decision about the technique. But once you have a model, whether it's digital or analog, you can do anything with that. Okay. All
right. Okay, I think there's just one. This is going to be the last question. And anybody who wants, I know some people raise their hand if you want to speak, you can. But there's a question here from Mubarak. It says, "What if an implant needs to be removed? Can you re-implant it?"
Once the implant is removed, you have to let it heal. Sometimes, if you have the site that is narrow, which means the implant, for example, you end up having an implant that is too, it's a very narrow diameter implant and you have more bone width, then what you might end up doing is on the same day, you prepare the area to have a wider or longer implant to have a primary stability, if you feel that the area is not infected. So people have done that. Okay, but if the implants fail, that tells me something's, infected already in the area. So maybe there isn't enough bone. So what I find is that some surgeons will just let it heal on its own, and maybe have to go back and do some more bone grafting before you can start placing another implant again.
Okay, thank you so much. Dr. Ene, you raised your hand up. I saw you. You are able to speak if you have a question. Ene Abba and Dr. Paul Wodika, are you able? If you're able to speak, you can unmute yourself and ask your question. Dr. Paul, do you have a question? Okay, I saw your hand up earlier. But anyway, I think you'll have to, we'll need to bring you back. I know it's a lot, but you have covered considerable, and I think the single implant. So this is going to talk about the temporization.
Yes, because you want me to include that, but I thought maybe too much, and but yeah, I'll be happy to do another one if you want me to, just to cover this part of it.
What date will work for you? What date?
Sunday's great.
Okay. Okay. So I would send you a message. Just give me the convenient time, and we'll schedule. Okay. But this has been very, very, a lot of people, we have a full house today. A lot of folks from Ethiopia, from Kenya, Nigeria. And I want to thank you guys for your engagement. You guys have been here solid. We had everybody, staying on. And thank you so much. I really appreciate it, Dr. Leung.
I hope you find the material useful, because again, I don't know the audience, and I don't know if it's too advanced, too easy, but I hope everyone will walk away with something useful.
Yes.
So.
Yes, yeah, definitely. Anyway, I'll reach out to you back, but definitely for those who want to, you would like to come for an in-house training in Canada and Ontario, the program is solid, and I would send the information through our Telegram groups for anyone who is interested. Obviously, you have to get a visa and a place to stay, but it's 5 days, right? 5 days of.
It's actually 3 weekends. So if you want something customized for your group, I would have to reach out to Sanjay, because it's customized to have 3 weekends. I'm doing the first 2 days, and then a surgeon is doing just a surgical placement, and I'm going to do 3 days at the end. So I'm responsible 5 days of the 7-day program, and this is designed more for the Ontario dentists. But if you guys are interested, I'm sure that Sanjay will be open up to customizing the program, so you don't have to fly back and forth for 3 weekends, yes, right?
Yes. That would work. Anyway, we'll make it happen. It only gets better. It gets better with every plan that we're making. Thank you so much. I really appreciate it. Thank you, Doctor.
Thank you for having me. I hope you enjoy the rest of the Sunday.
All right, you too. Take care.
All right, bye.
Yeah, bye-bye.